So welcome back. In this case, in its part one, we have discussed about the clinical presentation of a 37-year-old lady who presented to us and we made the diagnosis of wall prolapse.
Yes.
In detail, we have discussed about her history, about her examination finding. I strongly suggest if you have missed that one, before starting this video, please go there and watch that video and then come back here, because today we are going to discuss the management, which includes the plan of investigation, how we investigated her, and how we proceeded. Okay, so wants to keep it a mystery that what we did, whether surgically or conservatively. So I'm okay to keep that mystery. So let's start with that. So that patient was admitted with us.
Yes, ma'am.
How did you proceed, or how did you investigate?
We did her complete blood picture, the renal and liver function tests, coagulation profile, her thyroid levels, her sugar levels, and we did a screening general abdominal ultrasound in which we had to, in case we would find any mass or any other pathology, to rule all of that out, we did a general abdominal ultrasound as a part of the pre-op work.
Yes. So this is very important, though we do not want to do any imaging to confirm the prolapse. But you said that we want to rule out any pelvic mass, any ascites, if any other abnormality we can find out. Screening is very important. But I want to add one more point to it. This is also very important to look for the kidneys. Okay. So kidneys, what happens that many a times we have found that these patients who are having prolapse, either uterovaginal prolapse or wall prolapse, what is the physiology? The organ slips down. With this, the uterine arteries slip down.
Yes,
and uterine arteries are crossing the ureters so, at the level of internal os. So because of the pull of uterine arteries downwards, the ureters get blocked or tanked.
Yes,
okay, which causes hydronephrosis. Now this hydronephrosis resolves on its own if you operate on her. Okay, if you do some surgery or reposit the uterus back, anatomy changes again and hydronephrosis settles on its own. You don't have to do any stenting or any other procedure for that.
Okay, ma'am.
But important point here is that this hydronephrosis to settle, it takes 6 weeks to 8 weeks time post surgery. It's not that today you have operated, tomorrow hydronephrosis is gone. So so first thing, we need to see the kidneys to find out if it is affecting the ureters and causing hydronephrosis. That is the one important thing. But secondly, it is also important to save you from medical legal issues.
Very
now imagine a situation that you have not screened the abdomen before. You have operated on a wall prolapse or a case of prolapse, and maybe day 5, day 10, patient has, because of some reason, pain abdomen. She goes to a doctor who first line imaging, management or investigation, does an ultrasound for her. Now this ultrasound shows hydronephrosis, though it was from before only because of prolapse.
But we have not made a note
diagnosed. It was never diagnosed before. So the doctor and even the patient feels that it is because of some complications intraoperatively. Because all of us know that ureters are easy to get injured during any
stenting is not required.
No. Okay. Even if there is hydronephrosis, you just have to remain away from the
ureter.
So stenting usually in cases of prolapse, I don't do.
Okay. Not required.
Not required.
Even ma'am, for like anatomically, just to for
in vagina, actually, if you have seen Suvrati, some stents were operatively. Have you tried to feel it? It is not. We imagine that when we put a stent, we will be able to see or feel the ureter very nicely.
Okay, ma'am.
But in the real world, I have seen it, I have done it in the beginning of my career. It is not very easy, despite you putting a stent. To
that visualization
never can happen. It doesn't start to stand out like a rod.
Yes.
Even if you feel the palpation is not very confirmatory. Okay. And you tend to do, I feel that, and literature also has mentioned at some places, that you tend to do more damage in doing extra procedures.
Yes, that's true.
And you have to be safe. You have to follow the basic principles. You should not go near the ureter.
That is the safest thing.
Yes, safest thing. And even if you have injured the ureter, Intraoperatively, it is easier to diagnose that injury when stent is not there.
Okay.
Because the urine will leak,
yes,
and we give pyreteum before.
Oh, yeah.
Okay. So yellowish fluid. If there is stent, maybe if you have injured a little bit, it might not be evident at the time.
Okay,
so I have left this
practice of preoperative
stenting.
Okay,
one kind of ureteric stent which still thrills me, excites me, is the one which now newer versions of laparoscopists are using.
Okay,
when you do laparoscopic surgery,
the illuminating ones,
yeah,
the illuminating ones,
yes.
Those would help,
yeah,
or at least look
but I don't know how much cost it increases, but definitely that technology,
yeah, we would like to use it, yeah.
Yes, but for simple stenting, I don't prefer. I always teach to follow the basic principles of surgery and to stay away from the ureters. And if by chance things will happen with you, if you have damaged the ureter, identify it on table. Okay, and try to
and even manage it. Giving pyreteum that we do, it should be a universal practice. It will help all surgeons.
It has helped a lot.
Yeah.
And we have been doing it for I think
many
10 years or so, and it really helps. It gives you confidence if there is no, and especially for surgeries of urogynecology where you are so scared that you might injure bladder, it really gives you a lot of confidence that there is no leak of orange fluid, so I'm safe.
Yes,
it gives you a good sleep also.
Absolutely. So coming to, what should I tell you, ma'am, next?
So imagine we have told, now you tell me, now everything is perfectly fine, patient is fit for surgery, patient is admitted. Now you have to decide, you have decided that you are going to do a surgical management. We are not discussing many videos we have done, why not pelvic floor exercises, why not a pessary. So we are not, wall prolapse, it doesn't help, you have to ultimately resolve to
and this is an out and out stage 4 wall prolapse where pessary has no role whatsoever.
And pelvic floor also is not that
by good. Exercise she can't do anything
it will not go inside. But yes, exercises you have to teach us an urgent management
and post-operatively.
Post-operatively adjuvant management. Okay, that's the only role. Finally, we have to resort to surgery. Now surgery we have to decide whether we want to do abdominal surgery, whether we want to do a vaginal surgery. So what options in abdominal surgery we have? First, let's discuss that.
Yes, ma'am. So she has sacrocolpopexy and pectopexy as her abdominal surgery options. Yes, ma'am.
Which can be done by either of the 3 ways. What are those ways?
Open,
laparoscopic,
robotic.
Okay. So robot we don't have, so the option is gone. But if you have, you can try. Actually, robots make these surgery very easy. Robots are not meant for a simple hysterectomy or simple salpingo-ovariotomy. They are very helpful in difficult procedures like Birch-Kolpe suspension, sacrocolpopexy, all these procedures. And if you have like
the option of doing robotics,
we should have robot one day in urogynecology.
Yes, ma'am, definitely.
Okay. So this is
and now most of the videos also are robotic for this for sacrocolpopexy. So it actually looks very clear, like textbook like.
It makes it very easy also. So specifically meant to urogynecology, there is role of robotic surgery.
Yes, ma'am.
Okay. So now abdomen, this one. If you want to do vaginal, what are the procedures we have?
Ma'am, sacrospinal fixation is there in. And that, ma'am, high uterosacral
ligament fixation. One more, if patient is not sexually active, colpoclysis. So 2 procedures abdominally and 3 procedures vaginally. Okay. Now colpoclysis gone. Again and again we have told that patient is sexually active.
So we obviously can't resort to that.
Now we have to choose from 2 abdominal and 2 vaginal. So let's choose the route first.
Yes, ma'am.
Okay. Anything you can do if you choose the route.
Yes, ma'am.
So which route will you prefer for your patient?
Abdominal.
Justify your answer.
Okay.
You are right, but I need justification.
Yes, ma'am. So firstly, ma'am, my lady, she's had a prolapse from such a long time ago. She had it during her second cesarean. She's undergone a repair surgery. Her uterus is gone. After that, again, she has developed a wall prolapse. So she's somebody who's prone to this. So we would want a procedure which holds.
One more thing you told, Maybe she has some congenital defect.
Congenital, yes, ma'am. Some connective tissue disorders there, because we also saw the abdominal wall was weak. There is an umbilical hernia. So that thing. So another thing, what I'm saying is, so she's somebody who's already prone to this. So we really want a surgery that holds. First thing is that. Second thing is, she's young, she's sexually active, so we want to keep the length of the vagina. So we want something that facilitates a longer length also. So that is why abdominal in her case would be a better option.
And we want more sure shot.
Yes, like something that really holds. Yeah.
So if you look at it, the major difference in abdominal versus vaginal, vaginal we do with just the help of sutures. Either it is sacrospinous fixation or high uterosacral ligament suspension. Only sutures are holding. However, even if we do pectopexy or we do sacrocolpopexy or colposacropexy, whatever you want to say, we use a mesh.
Yes,
so mesh, what happens in that mesh? Fibrous tissue goes in and it makes a nice
stronger support.
It's a stronger support. Okay. So the chances of theoretical also, the chances of failure are much less. And this patient is just 37.
Yes, ma'am.
She will leave the management when your thought process is going on. You will think differently for a 60-year-old lady, for an 80-year-old lady, and a 37-year-old.
Definitely.
You want a more lasting effect for this person, definitely. You cannot keep on operating her again and again. Okay. So we chose.
Ma'am, her risk factors also are not going to stop. Like, she is going to resume her work.
Yes.
She is sexually active. She will now sadly only put on weight. So things like that.
Yeah.
So we want something that is going to really stay strong all through.
Yes. So we want to do it abdominally.
Yes,
we want to do it procedure which uses a mesh, which is abdominal procedure. Now once we have decided the abdominal route, whether you want to fix it with the sacrum or pectineal line, whether you want to do a sacrocolpopexy or you want to do a pectopexy.
Ma'am, we'll do a sacrocolpopexy in her case. I think because ma'am, I think the support with that is better. Is
more anatomical, yes. It is directed in the direction of vagina. You are correct in your answer. But as a team, if we have to do, I will do it more because we have more evidence.
Okay.
This is a procedure which have known to give results.
Yeah, pectopexy is fairly new, right?
It's new. There is not much data. There is not much evidence for pectopexy. So when I want little short, I'll go back
to experiments in her case.
Experiments in her case. Maybe for small prolapse, you can try. For an old lady, you can try. But definitely not in this case.
Yeah.
So we chose to do a
sacrocolpopexy.
So sacrocolpopexy is mostly known as sacrocolpopexy, but many people use the other name also, colposacropexy. Because sometimes the confusion happens. One is sacrospinous fixation, one is sacrocolpopexy. So both names sound similar. So these days many people use the word colposacropexy.
Okay.
But whatever it is, the meaning is simple. Colpos means vagina, end of the vagina, we are anchoring to the sacrum. Okay. So either you say sacrocolpopexy or say colposacropexy.
It is stays the same. Yes.
And we are using a mesh here. Now some anatomical points.
Yes.
Okay, let's discuss that which part of sacrum you want to fix this mesh.
S1.
S1, very good. More anatomically correct though is S2 and S3, where the vagina is directed.
Yes.
But why don't we go to S2 and S3?
So much nerves and all of that.
Yes. So most of the venous plexus nerves are in the lower part of sacrum. We want to play good, but we want to play safe.
Yes.
That's the dictum. So little bit 1 centimeter up and down doesn't matter, but it gives a lot of safety. Anatomically does not matter that much. But safety wise, we are going to fix it at the level of S1. To which ligament so?
Anterior
longitudinal ligament. On little will remain on the right side of, because midline again, the middle sacral vessels come. Okay. So we don't want to go, we want to remain towards the right side. Okay. This is one anatomical point. Anteriorly will come to surgery also, but let's understand. So one mesh will fix here, and the other part of this mesh comes to the vault.
Yes, ma'am.
What points we fix this mesh? Do we fix at the apex of the vault?
No, ma'am. We fix it along the anterior and the posterior aspect.
Very good. So we have to take care of. You said that she had cystocele,
Yes.
she had enterocele. If you just fix at the top,
you're not taking care of those defects.
Yes. So what we have to do, we have to dissect bladder
Yes.
around 4 to 5 centimeter down. We have to dissect the pouch of Douglas 4
Yes.
to 5 centimeter down. And so the shape of the mesh is
Y-shaped.
Y-shaped. It's not as band.
Hmm.
And do we get this? Are we buying this Y-shaped mesh?
No, we are not.
Because I don't know whether it is available or not. When I came back after my training in Germany, they were using a Y-shaped mesh. That time I tried to find out, but this mesh was costing 80,000 that time, which was too much for our population. So what we do homemade. Okay. So how do we create the mesh? It was created by you. Tell to how.
So, ma'am, we took a Prolene mesh, which is used to repair the hernias. Inguinal hernia or umbilical hernia, whatever. So we took that mesh, and it's available in various sizes. We have to think according to our thing.
And which size? Mostly the size which you use
is the small size, ma'am. It's 7 into 15.
7 into 15.
Yeah.
This is the perfect size for us.
Yeah, it really worked well. So we took that size, and now what we have to see is that we take this mesh and the length, which is 15. Along that, roughly we take about 5 centimeters. Like ma'am said, that we have to dissect 5 centimeters. So to make our flaps, the anterior and posterior, at that point, like first we fold it, ma'am. We fold it.
First thing is we fold it.
Yeah.
So when we fold it from a sheath, it becomes a strip.
Yeah. And we have to crease that.
We have to crease that. And we have to put some sutures.
Yes.
So that it stays that way.
Yes, ma'am. So when we are doing that, we'll have to mark a point which is about 5 centimeters, and we can like hold these two, and in between we have to place the sutures to make sure that our flap stays closed. And then from this 5 centimeters wala point, we have to make a cut.
Yes.
And then so that gets divided into 2 halves. So this is our homemade Y-shaped mesh.
So if you are confused now when we are discussing it in theory, if you really want to know, actually Suvrati has made a video. Yeah. I have not seen it yet, but she was making a video that day.
Yeah.
But for that you have to request, you have to post a comment below so that we can
post that. No, but I think,
ma'am,
I should do like a cleaner one now that I've understood how it is done.
Okay, yeah. But if people want to see, we can show them. Okay,
how we are actually doing it.
Yes. Okay, so this mesh is ready now, and we have understood in our mind what we want to do.
Yes.
Now the second question from you is, when we are opening the abdomen, should we open it midline, or should we put it in fashion of like transverse
incision? Yes. So ma'am, we will put a transverse incision, a muscle cutting incision to be precise, because we want maximum exposure. Second thing is, all the things that we need to deal with are properly visible in that area with a longer, like not longer exactly, but a wider field.
Yes.
Yeah.
So always remember, many people give that longitudinal midline incision, but I feel always it is much more scientific and much more easy to give a transverse lower abdominal suprapubic incision, and muscle cutting will make it more spacious.
More spacious.
Okay. As you said, that all our organs of
interest
are in that area.
Yeah.
Okay.
Then after that, ma'am,
always expect adhesions, because patient has undergone surgery.
A previous cesarean. Absolutely. And which was true in this case. There were many adhesions
and
also.
Not just cesarean.
Yes,
you cannot just think of cesarean. She has undergone a vaginal
hysterectomy on top
Though
of that.
You are thinking that abdomen was not open, but you have entered the peritoneal cavity from below. Okay. So it will cause some kind of adhesions in the abdomen. So be very careful when you are opening these kinds of abdomen.
So ma'am, firstly...
So did you find adhesions?
Yes, we did, ma'am. And we had lots of adhesions. We had to do a lot of adhesiolysis. And after that, we went on to create these windows that we needed. So, should I start, ma'am?
Yes, please.
Okay. So, firstly, we went behind and we had to expose the area of the sacrum. So, our dissection started in between we visualize the ureter, and we have to sideline the colon.
Yes. It is sigmoid colon.
Sigmoid colon.
Yes.
And then after that, we start to dissect in that area, and till we reach the anterior longitudinal ligament, which looks like a very clear whitish strip, which you showed all of us in the OT. So once we find that, then we have to use you said 3 sutures, ma'am, along that anterior longitudinal ligament. And these are going to be our anchoring sutures for the mesh later.
What suture material it should be?
Ethibond, ma'am.
Ethibond. It should be a non-absorbable
Non-absorbable suture, yeah. So we placed these in upward to downward fashion, and we placed about 3 of them because we wanted to make sure that we have strength. Yes, ma'am. And we tagged them. So these are the ones we'll use to anchor with the mesh later.
So posteriorly not, though it is difficult to work in such a depth, but usually if you think stepwise, you just have to identify ureter, identify sigmoid colon, give a nick in between, keep on dissecting till you reach the white shining ligament. And once you reach the ligament, without injuring the small vessels, you have to
be very careful. Yes.
And why we have to be very careful? Because these are just vessels.
But these are sacral vessels.
These are sacral vessels. What will happen?
We won't be able to do anything if we they will bleed so profusely if we injure anything.
If we injure anything, they will start bleeding profusely, and it can be life-threatening hemorrhage.
Yes.
What is the difference between these vessels and any other vessel of the body is that you can compress it with pressure. Or with some artery forceps, you can hold.
But these will be so retractile, we won't.
They will retract inside the sacrum.
We'll never find them.
And then there is no compression inside the sacrum. The sacrum will start oozing. Then if this situation unfortunately happens with you, what is the last resort you have to stop this bleeding?
Last resort to stop this bleeding?
Because it will keep on bleeding. There is no compression of the blood vessels. They have retracted inside.
Aorta, ma'am? No,
you have to put bone cement.
Oh, bone cement in order to stop. Okay, no, I had no idea. Okay.
So you have to push bone cement inside, and also it is a very tricky situation. So prevention is the best.
Yes, absolutely.
So this thing is done. You have to be very careful. Then once you have taken bite, you leave them there tan. Then move on to the anterior compartment.
Yes, ma'am.
So how do you start anterior compartment dissection?
Ma'am, we start with first we'll go to the anterior part, like we separate the bladder.
First, you have to tell your assistant who is sitting there to push the ball down.
Okay. Yes.
Then only you can
then we'll be able to make out. Yes. So we used a sponge-on holder, and the person who was at the vaginal end, they had to place that inside and push the wall down. So when they do that, since it bulges out, we are able to tell the things apart. And then we go anteriorly after we know.
So if you have a doubt in finding out the margin of the bladder, till where the bladder is, from where the POD starts, what we did something, you have to push little fluid inside, saline inside the bladder, so that now you
can
get
area will also,
But you have to drain that fluid before starting the dissection.
Yes, definitely, ma'am. So we did that. We delineated our planes, like where is what, and after that we started the dissection. So like ma'am said, we are going to create about 5 centimeters ka window in the front and at the back.
Plain, I'll say.
Plain.
If you think
no, not a window. Plain, yes, plain.
So anteriorly you create a space for 5 centimeters. Posteriorly you dissect the peritoneum for 5 centimeters.
Yes,
luckily this patient had was not having, sometimes what you might see that some bubble is attached in the POD.
No,
luckily that was POD was free in this patient. That was a good point. Now you have to fix the mesh.
Yes,
one limb goes anteriorly, one limb goes posteriorly. So then how do you fix these? Do you have to fix or you just leave them there?
No, ma'am.
You have to
take
fix
sutures.
So what sutures you took here?
Ma'am, we took Prolapse. Zero Prolapse.
Okay. When mesh is non-absorbable, to anchor it also we should have something which is non-absorbable. Otherwise it will get displaced in few weeks time.
Yes.
You should remember that. Don't fix it with Vitral.
Yes.
Okay. So then we took proline, because 2-0 proline we took. And when you are using proline, you have to be very careful that it should not go through and through from the vagina.
Yes.
Otherwise this non-absorbable suture
will irritate the
vagina.
Yeah.
One more practical tip which you did, Suvrati, like which we did at that time, when you are delineating, then you can put a sponge and holder inside.
Yes, ma'am.
But when you are
suturing the mesh, you're supposed to replace that with a more solid instrument.
Yes.
Because if you have the sponge on holder and through the sponge if you take a stitch, then you're in soup.
Yes.
So we made sure, and we told everybody to remind us. So when we were fixing the mesh, we got rid of the sponge on holder and we placed an inverted Devers retractor in our case.
Yes.
Because since there was that curve of the retractor, that was making sure that our vault stayed up, like the purpose was being served.
Sorry. There are some special instruments for that, but if you don't have, you can always do jugaad. Okay, you will always find something which can help you if you know what you want.
What you want, yes.
Okay, so we did it with the other end of the reverse retractors.
Yeah.
So mesh was with 5 sutures in front and 5 sutures behind. We fixed this mesh.
Yes, ma'am.
Now comes the most important part. Okay, you have to fix it before, but before that only, it is preferable that you peritonalize this area.
Yes,
okay, so how do you peritonize? You have to take one bite with the help of vitral now. Okay, I think the most important, if you want to reduce the complication, good dissection is one thing, and again putting it inside the peritoneum is another thing.
Yes.
Okay, so entirely you have to peritonalize in a purse string
fashion,
so that the mesh, which is anterior posterior, is totally
it's
out of the
retroperitoneal.
view. It's retroperitoneal. Now you take the other end, the long end of
tail
the
of the mesh,
tail of the mesh towards sacrum, and see the distance, because you will again have to trim this.
Yes.
It is a 15
We had to in this also, like when we had placed the 5 centimeter mesh, even then we had to trim the edges.
Yes,
a little bit.
You have to trim the edge anteriorly also and posteriorly also. So posteriorly, when we are trimming, one important point you have to keep in mind that the mesh should not be too tight. It should not be under tension.
Yes.
Because what is going to happen in 1 month, 2 months, 3 months
when
time,
fibrosis, anyway it's going to shorten.
Will contract.
Yes.
Okay. So if now you were asking me again and again that why can we keep something in between the rectum?
Yes, ma'am.
Because I think you were a lot worried about erosion of the mesh.
Yes, ma'am.
Now here for everybody, I want to make a point. That erosions inside the viscous are not common, are very, very rare.
Okay.
If you have injured, even if you are doing TVTO kind of procedure, the injury, the erosion inside the bladder or urethra will happen only in those cases where you have damaged peroperatively. Okay, erosion usually are very, very rare to happen spontaneously inside a viscous. Okay. So mesh will just like that
damaged peroperatively
means if you have put the trocar through the bladder. Okay. And you have not realized it.
Okay.
And mesh has gone through there. That time patient will be.
But you've already made some rent.
Already made some rent.
Okay.
That is the time when viscous will have erosion. Okay, you might not realize it that time if you don't do a cystoscopy. Okay. But to enter, for mesh to enter a viscous which is totally not injured.
Okay, that is
it's rare. Not common. Okay. So mesh erosions are more common through the vagina.
Right.
Why? Because it is always infected. Infected means a lot of bacteria flora is there. It's in a sexually active person that we are putting these meshes. Okay. So these people are some kind of activity, friction is happening all the time, and it is exposed to the environment. So vaginal erosions are more common. Don't think that this mesh will start eroding the ureter. No, it will not, because they are fixed structures. It will not erode the sigmoid colon or rectum also. It will not.
They are fixed and intact
structures. Okay. But why we have to do this peritonealization so religiously? Because it will predispose to adhesions. And suppose this mesh is laying there in the abdomen. It is like a band. After fibrosis, even more stronger band.
Yes.
And the risk, what we are anticipating, is of bowel obstruction.
Bowel obstruction, I was just going to say that. That is it is just exposed like that. Even ma'am, like strangulation and all.
Strangulation. So that's why we want to keep it totally inside retroperitoneum. It should not be. Now when you are doing, if you are doing it laparoscopically also in easy cases, you have to be very careful that everything is inside.
It's hidden. You should not be seeing
anything at the end of the surgery.
Then we took the tail and we attached that to our. So we have left those sutures initially, which we had tagged. So through them, we make them pass through this tail of the mesh and then we tie it. So now our Y has nicely settled on the vault and the sacrum. And we have done we have closed the peritoneum also. And at the end, we need to ensure that we don't see the mesh at all, like you said, ma'am.
So with vitral 20, we close the entire section. Wherever we have cut, we have to close it.
Yes.
And that actually finishes the surgery?
Yes.
Is it?
Yes. No. Yes. What we said. So initially, when we'd spoken about our examination and we did that measurement of the genital hiatus and we saw that it was around 9 centimeters, that time in our procedure we had decided that we will do a repair and we will perform a colpoperineuraphy. So we went there and we finished that as well.
Yes. So a good perineuraphy. Usually, I do not do levator ani fixation in the midline. Okay. But this patient had such huge genital hiatus that I have done little plication of puborectalis muscle.
Okay.
So that was important. After that, she had a good perineal length, one normal size. You should not constrict her introitus too much. So normal size introitus she had, abdominal she was okay.
Yes.
Vault has gone up, so patient was fine.
Yeah, there was proper hemostasis, smoothly done. And we closed the abdomen.
Yes. And patient is fine now?
Yes, ma'am. She's doing totally fine. Yeah, she started eating.
Okay.
Yeah.
And post-operatively,
yeah,
any problems like when we do sacrospinous fixation?
Yes, ma'am.
I always tell that post-operatively, just remember one thing, that there can be pudendal neuralgia.
Yes.
Okay, keep that. Don't say that, because if you don't know, if your mind does not know, then eyes
you're
won't
going
see.
to think that it's a very serious thing,
or something you might just ignore also.
Yeah.
So making a diagnosis is important. Remembering what
could
surgery can have some specific complication, you have to have in mind.
Yeah.
Better to educate patient also.
Yes,
this may happen. Okay. So sacrospinous fixation, I tell only one thing. For this sacrocolpopexy is dyschezia.
Yes.
For 1 month or so, many patients come and they tell that they are having burning or pain during passing motion. Because of that irritation, maybe the mesh is next to the rectum and it is trying to contract. But it is again a self-limiting problem. You don't have to
do anything for that.
Maybe
laxatives, man.
Yes. Laxatives. You must teach her about diet.
Yes,
some soft diet which is easily
fiber-rich
diet, which does not make a very hard stool. That kind of diet will be good for her. And otherwise, patient will be fine. Now she has slowly started taking oral things. So she's not complaining of anything, but she might come to you. Better to educate her that this problem can happen. So
but it will be self-limiting. Yes. And we have to tell her about abstinence for 3 months.
Yes, important
point.
Yes. So any other questions, Suvrati, you want to ask?
About her?
I think we have discussed many points.
Yes.
And if you guys want to ask any other question, don't forget to ask your question.
Ma'am, but we should do a video on pectopexy and hystropexy, these new procedures.
We'll do it. Hystropexy, actually, there is a video. In our very beginning, when Dr. Finfeld had come to MUC first part.
3 years back.
3 years back, 2019, there was a case of hystropexy, again in a young lady. And actually, she keeps on coming for follow-up and she's perfectly fine. I think 3 months ago, she had come for follow-up. So this is a feedback
before
also.
I came.
And, but you were there when this sacrohystropexy was done during that conference. So that video is there. You can watch that video. But yes, pectopexy we don't have any video, but we'll soon do that. Okay. So I think with that, have a very safe and happy Diwali. And don't forget to bring little sunshine, little spark to somebody's life, because God has given us this power to make a little change which others can't do, which money cannot buy. So please do your bit. It is going to make a change. Thank you so much.
Bye-bye.